Well, welcome back, everyone, to the second section of our GU committee. I just want to kick this off by telling you that the grant will be going in the next 8 months or so, and 8-9 months or so. And so there are two items that each one of us can do to help. One of those items, and it will be the organ site chairs that will help with this, is to ensure that every manuscript that needs to be written is written and submitted. And obviously the reason for that, when you can put in press at a given journal, it will seal the deal for the reviewers. And the other piece is that vis-a-vis the panel that you just saw, every single accrual that we can achieve between now and then, and actually, going forward, will help the grant. The COVID time was especially problematic for SWOG, disproportionately problematic for SWOG over the other cooperative groups. And you'll see the new, so it will be imperative for all of us to do everything that we can do to accrue patients to these trials. So every one of us go back, convince our colleagues. I will tell you that one thing that you can do is to reach out to the study coordinator or the study PIs, and they can come and they can give Zoom presentations to your faculty, Zoom presentations to your residents, to help educate folks, talk about tricks of the trade. I know that every PI would enjoy speaking to your CRAs and to other referring physicians like medical oncology, urology, all the other specialties. So take advantage of those. Take the list of the currently open GU trials and go home and send an email to the study PI and say, I'd like to see what I can do to improve the accrual to your trial and participate. This is, after all, this is a group effort. This is team science. And for the junior folks, one of the quickest ways to become a more active member of the committee is through accruing patients to the trials. So without further ado, you're on.
Yeah, thanks. While we're getting the slides up, I'll also just add a little perspective to that as sort of thinking back to my days on the task force and GU steering committee that, there's a huge amount of time and effort, not just within the GU committee and the larger SWOG enterprise, but really across the NCTN and the review process and CTEP to get these trials open and activated. And essentially CTEP has endorsed the science, right, that's gone through amazing number of levels of peer review. And so once we commit to a particular trial, both scientifically and operationally, we have an obligation to sort of see it through, as long as the science still makes sense and everything else. So, we've got, you see the results of that effort with PROBE. I mean, it's really encouraging to see how accrual has picked up a bit. There's still a long way to go, but we really need your help with 2011 and 1937. These are great studies. The PI and the teams have been very flexible in making amendments to make it easier and remove some of the barriers. So now it's really time for us all to get behind this. So I appreciate everybody's support. Okay, so I guess you want me to come up there real quick? Sure. Yeah, okay. So we're going to do bladder and then kidney, and let's see, yeah, okay. So for those of you who don't know me, I'm Seth Lerner. I'm a urologist at Baylor College of Medicine. I chair the local bladder committee, and my colleague Tom Flagg at University of Colorado chairs the advanced bladder committee. We have a monthly call Wednesdays at 4 o'clock Central Standard Time, and the purpose of that is to talk about new concepts, trials in progress, and really work with the PIs and the study champions to help kind of move things along. Megan, I don't know, Megan, are you here? Yeah, there you go. We're indebted to Megan and her efforts in supporting us, and we have a new patient advocate who, if you were here yesterday, you met Daryl Nakagawa. Daryl, thank you, welcome. And I don't know, is Rick here? Rick, where are you? Rick is been our longtime patient advocate, and I just want to reflect a little bit back when, oh gosh, 10, 11, so probably 12 or 13 years ago, Ian and Nick had the great idea of making Rick Bangs a study coordinator, one of the co-investigators on a trial. And as you say, the rest is history. And Rick's just been an amazing partner for all of us in the bladder community and the larger SWOG patient advocate community. So hats off to Rick. We're going to miss you, but I heard yesterday he's going to stick around for about another 6 months or so and help Daryl with the transition. So welcome. This is our agenda. We'll go a little bit over again, just for points of emphasis, although we just went into detail about 1937 and 2011. There may be some new folks in the crowd, so we'll just sort of run through those briefly. We've got a number of concepts in development. We'll bring you up to date on that, and then talk about our active and other NCTN trials and our study champions, and we'll have a little bit of time, I think, to briefly discuss 2 new ideas to get some feedback. Okay, so Sarmad and then Guru. The abridged version.
Thank you. For new audience members that joined just now, we discussed this study. This study is suffering from low accrual, and we need help to increase it to meet our accrual goals. This is a phase 3 study of eribulin plus gemcitabine versus standard of care. Now that we have a new change in standard of care by introduction of enfortumab vedotin plus pembrolizumab in frontline, the landscape has changed significantly, and patients will be eligible for this study at an accelerated pace, especially those that are not eligible for cisplatin. They will get the combination of pembro plus EV in the frontline, and very quickly we'll find ourselves out of option. Some discussion has been around, okay, what is sacituzumab? How does sacituzumab fit in this landscape, and does it compete with this study, etc.? So I just want to quickly remind everyone that sacituzumab govitecan after immunotherapy had a response rate of 27.7%. That's the basis of the accelerated approval. It is currently in a phase 3 against docetaxel, paclitaxel. I think the accrual is completed. And eribulin and gemcitabine eribulin combination, they've been tested in phase 2 studies with impressive response rates, activity in liver metastases, which is always a concern in this disease for all of us. So I think a lot of these patients are going to be if you're considering sacituzumab govitecan, docetaxel, a phase 3, a phase 2, a phase 1 for your patient, I think SWOG 1937 is an equally good option for all of these patients. These are the data that I've already shown for eribulin and gemcitabine eribulin with activity in liver metastases. And this is the current design of the study, as we discussed. We are going to, in response to this change in the standard of care, we're going to make some modifications, modify the eligibility criteria, allow patients to enroll on this study without regards to the number of lines of therapy, as long as they have done pembrolizumab and enfortumab vedotin. We are going to consider them eligible patients. If there is a contraindication for immunotherapy, then they don't have to have immunotherapy. The criteria list measurable disease. It is a requirement, but if your sites of metastatic disease are only in the bone, then those patients are also eligible. The primary endpoint is overall survival, not response rate. So the amendment is going to fix the eligibility criteria. We are also thinking about dropping one arm. We always thought gemcitabine eribulin combination was better than eribulin alone. So eribulin monotherapy is going to be dropped from the study, and the statistics are going to be simplified. Therefore, we're going to have a smaller sample size. This allows us to have a lower accrual goal per month of 3 patients. I am really grateful, and I can't thank you enough, those investigators listed on this page that have participated and supported this study, put patients on this study, and I hope more of you will join this study regardless of the amendment and how good the idea is, et cetera, et cetera. Without your support, it's not going to succeed, and we really, really need that support. So I am happy to, as Dr. Thompson mentioned, do Zoom calls, discuss and present the study at your disease group meetings, and help in any way I can to move this study within your site and open it. And these are our study team members and colleagues from other cooperative groups that I'd like to acknowledge here. I'm going to stop here and answer any questions you may have. Thank you.
We would just say there's about 40 people online, so we can see the chat there. If you have questions, feel free to enter it there as well.
Okay, so the SWOG 2011 trial, also called the SWOG GAP trial, is a randomized phase 2 trial looking at combination gemcitabine, avelumab, carboplatin versus no neoadjuvant therapy, preceding surgery for cisplatin-ineligible muscle-invasive urothelial carcinoma. So this is the design slide. So it's a randomized phase 2 trial. And if you go from left to right, the eligibility is simply muscle-invasive disease, bladder or upper tract. In the case of upper tract, we allow high-grade plus mass lesion on ureteroscopy or imaging. Patients are cisplatin ineligible by conventional criteria. You need predominant urothelial component and no small cell component. And then the patients are randomized after stratifying for stage, performance status, and creatinine clearance. You note that there is no stratification for PD-L1 IHC, so there is no central PD-L1 testing, which has been a requirement in basically all of the ongoing large phase 3 neoadjuvant trials, which has led to a delay in starting neoadjuvant therapy in many cases, in my experience, at least 2 or 3 weeks for the central testing. And so that saves a lot of time and anxiety for patients. Patients are randomized to surgery within 6 weeks. That's the arm on top, you see, the standard arm. And the investigational arm below is the gem-carbo plus avelumab arm. And then the patients go to surgery, which can be radical cystectomy, nephrouretrectomy, or uretrectomy. There is, of course, banking of blood and urine and tumor at these time points. And you know that after surgery, the adjuvant component is per investigator discretion, so there is no mandated adjuvant component. So what that means is adjuvant nivolumab would be allowed in both arms of the trial, actually. And so that's nice because patients are not really being denied access to immunotherapy, which a lot of the neoadjuvant phase 3 industry trials actually don't have immunotherapy in the standard arm. So, and then the post-op follow-up is as per convention. The primary endpoint is pathologic complete remission, and the secondary endpoints are event-free survival, toxicities, and we also bank tumor and blood and urine, and we're thinking of banking imaging in the near future. And we look at the, I don't have statistics listed on this slide, but I have it briefly in the left lower corner. You see the improvement in PathCR. We are targeting going from 15% from the standard arm to 35% in the experimental arm. It's a 1:1 randomization, and we need 178 evaluable patients. So there have been accrual challenges. This study activated in October 21. We have 5 accruals so far since activation. Of course, I do want to thank all the investigators that have accrued on this trial. It's can be sometimes challenging to explain to patients that they might be randomized to a no treatment neoadjuvant arm. But remember that there is the adjuvant component that is per investigator discretion, so we're not really denying immunotherapy access to patients. So the reasons for accrual challenges have been the delayed opening and activation of the trial at institutions, and I know that some sites were still activating earlier this year, so this is more than a year out after the trial activated. And then some of this has to do with local resources and staffing issues, and that's been a common problem across many institutions. And then the requirement for documented bimanual examination under anesthesia under eligibility was becoming a problem. It's difficult to quantitate, but I know personally at least 5 or 6 cases that this has happened. And so we looked at it carefully, and it does look like urologists are not routinely doing this, or maybe at least not routinely documenting this for baseline clinical staging during TURBT. So we actually amended the protocol to remove this recently, which I will get to in the next slide. And then the other 3 I mentioned down there are competing industry-sponsored trials, which have been ongoing for a while, and I think most of them have finished accruing. Maybe some are still open accruing in the neoadjuvant setting, so maybe those competing trials will go away if there are any in your institutions. And then the design of the trial, chemo-IO versus no neoadjuvant therapy preceding to surgery, might be perceived in the patient's eyes to be unattractive because of the no neoadjuvant therapy. But again, remember that we allow adjuvant nivolumab in both components of the both arms of the trial. And then the chemo-IO regimen itself, gem-carbo-avelumab, might be perceived to be somewhat uninteresting chemo backbone. However, I think that this is a regimen that is quite tolerable, unlike the more the regimen that's been more in the news, the EV-Pembro regimen, which does have toxicity issues with neuropathy and skin toxicities. So the amendments have been active very recently, since earlier last month, April of 23. So we have relaxed the timelines, as I've mentioned recently. Muscle-invasive disease is allowed within 120 days before registration. In the case of upper tract, we need a combination of high-grade disease and a mass lesion on the scope or imaging. The TURBT or ureteroscopy needs to be within 70 days before registration. And in the second TURBT, if the patient requires it, does not require to have muscle-invasive disease a second time. So if you have it at baseline, that's enough to qualify. And then the bimanual exam under anesthesia has been removed as a requirement. So now it's a recommendation under procedures. It's not a requirement. It's not an eligibility criteria. And then we clarified some of the dose modifications and other points in the protocol. You can hold one of the components of the chemo-IO regimen and continue the other if the toxicity is specific to one of the components. So that should not deny patients continuation of the component that is not causing toxicities. And then I'm available easily to answer questions by email. I also have my cell phone up there, and happy to answer questions.
What do we need to do? We need to get patients on this trial. Right? Any? This is, you know,
How do we get accruals?
Yeah. So
I mean, we should have a discussion because it's obviously lagging and it's going to come under scrutiny. So I don't know. Personally, at my place, we had a competing trial, and this didn't. But I'm gonna, because of some structural changes, I'll be opening this but I don't know if others are having problems with like the Volga trial or.
So I heard the regimen was not really exciting, but is there something more exciting in this space where we don't, I mean, the patients don't have a lot of choice? That would be my question. I mean, the S0337 was not that exciting, but we changed the standard of care.
Right.
So what would be more exciting than this for a population that doesn't have a lot of choice?
Rick, I think it's an excellent point. So we obviously have level 1 evidence around cisplatin-based neoadjuvant chemotherapy. We don't currently have, and Guru has pointed this out, no level 1 evidence to support neoadjuvant therapy in the non-cisplatin eligible patient population. The majority of those patients are ineligible because of renal function issues. And so, and yet there's pretty good phase 2 data showing the activity of immunotherapy. We recognize that there's trials going on in this space. So you've got a wonderful opportunity to combine immunotherapy and a platinum agent in a patient population that otherwise just gets standard of care radical cystectomy. It's permissive. You can use, some people perceive standard of care adjuvant Nivo. I mean, I don't know what could be easier, maybe too overly simplified, but I know at our place we don't have a trial for these patients, so it's at the top of our list to get activated. We're fully aware across the country of the challenges with workforce and staffing, and I think we're all struggling, hopefully getting through that. But yeah, so we got a few people at the microphone. Ian?
Well, I was just
Rick,
going to say,
let me just, Rick, did you have something else you wanted to say? Sorry.
No, I'm good with the follow-up discussion that I'm sure is going to happen.
Good, thank you. Ian?
how many institutions have it open?
So about 15 institutions is a little bit, there's.
15?
Yeah.
Okay, well, that's obviously one of the challenges.
Right.
We need to get it open. But it strikes me that a trial like this, institutions could commit to every time that a pathology a path report comes off from a TURBT with a muscle invasive tumor, that someone in the protocol, the protocol officer in urology would look to see whether the patient is platinum eligible and just make sure that that becomes available to the faculty physician or the treating physician to let them know. This is one of these automatic sort of, if you put a process into place, but it's going to have to be open at a number of more institutions to be able to turn that around. And if everyone here could consider doing that and then just think about the number of patients with muscle invasive disease that would be that you would have potentially eligible for it, that would be a process that could be put into place.
Yeah, I think I'll just add that, this really has to be driven, it's obviously driven by the multidisciplinary team, but the urologists, we're the ones seeing these patients. They're coming through us, and we're the gatekeepers, and oftentimes we're the problem, which is an easily solvable problem. Lucky, and then Dan?
So at the professional review committee meeting the other day, it's become clear that 2022 for most of the SWOG sites had been a harder year for accrual than 21 and 20
Right.
Due to COVID. So I think the activation of this trial in late 21 sort of just it got bombarded by that late effect of COVID staff attrition. So that's one. But then going back to the enthusiasm of investigators over this combination, Guru, do you think the idea of combining a checkpoint inhibitor with a platinum-based doublet being ineffective in metastatic disease, the combination of not the sequence but the combination concurrently, may have seeped into this one, that lack of enthusiasm about no signal in metastatic disease of Atezo, for example, with the cisplatin-based regimen, and maybe that's infecting this concept as well.
Yeah. So there was actually a hint of a signal with PFS with Gem Platinum plus atezolizumab. There was also a similar hint with pembrolizumab, but it was not statistically significant. I will argue that those trials were actually underpowered because of the hierarchical testing. I would also say that the Gem Carbo, although it might have a perception of being boring, is much more tolerable than EV Pembro, for instance. You have to select patients carefully. It's not for everyone. So this regimen has toxicity advantages in this space, and actually any space. So I think the jury is still out. We're still awaiting the BMS Checkmate 901 trial, which is like looking at GemCis versus GemCis Nivo, thus targeting the cisplatin eligible patients only. So I think that the platinum-based chemo plus IO combination is not fully dead yet. I think that we still need to wait for some more data, actually.
Thanks, Dan.
2 points. I think that for VOLGA, which is one of the competing trials, I don't believe that renal pelvis tumor is included in that. So this is actually one area that you could exploit. And in fact, if you've got one open, you may be able to open both, because this would cover renal pelvis. Yep. And then secondly, as Guru was pointing out, one of the prerequisites for platinum eligibility is neuropathy, which would be a problem in giving EV in this situation. So I think that there are a couple of opportunities to do both of these trials at the same time, and then get accrual, at least on this study.
Yeah, good point. Thanks.
I just wanted to echo some of the suggestions. I think we had a competing trial with the EV Pembro study, so that has been an issue. So I actually think this is a really good time to revisit this and drum up some enthusiasm, and we'd be interested in opening it here at UC Davis. The other thing that I really liked that you've changed, Guru, is the time constraint for the muscle invasive diagnosis, because we've been very successful at accruing in the Alliance DDR alteration neoadjuvant study, and that has been the biggest thing that's screen failed patients, is that 90-day requirement. So I do think loosening that is going to help a lot. So we'll try to get people for you.
Okay, thank you.
Thank you very much for that input. So we're going to go into the 3 concepts in development, and I think Josh is on the line.
Yes.
There you go. Hey, good morning. Let me just preface this by, we've talked about the clinical trials partnership and exactly what it is. It's just to refresh your memory, it's it's an entity that sort of sits within SWOG, but it's really not part of the NCTN per se. So this trial functions more like a pharma-driven trial using the SWOG mechanism. So we've got some nice updates, and I'll turn it over to Josh. I can advance the slides for you.
Great. Thank you very much. Good morning, everybody.
All
Do you
yours.
want to go to the next?
Can you can see the slides, right?
I can. Yeah.
Got it,
So
okay.
great. So we did have some updates that are major updates to the trial. We've overall changed the concept a bit, but the overall hypothesis is the same. This is a phase 2 trial testing the role of subtyping in muscle invasive bladder cancer. We still have 3 arms, and we're still testing that versus neoadjuvant chemo. Next slide. So this is our inclusion criteria, and it's a platinum eligible trial for localized or N1 tumors. Next slide. This was our prior schema comparing each subtype to neoadjuvant chemotherapy. And if you go to the next slide, this is the current schema that was approved by the ERC just 2 weeks ago. There's a bit of an echo, so maybe Seth, if you could talk through it, I think that would be a little bit better for the folks there.
Yeah, I suspect there's probably a little bit of a delay too. Let me just go back here. So this original design was sort of our dream of having a randomized phase 2 for each of the major molecular subtypes. So luminal papillary, basal squamous, and then sort of we lumped everything else into a bucket. And there's the primary reason for that was each of those subtypes within that, which will be luminal infiltrated, luminal, and neuroendocrine were, or neuronal, would be relatively small. And so this design was roughly about a 650-ish patient trial, and because of quite frankly, because of budget restrictions from our partner, Roche Genentech, we had to drop the sample size. And really credit goes to Kathy and the team for working with us to come up with this. So now essentially, if you look at the bottom, there's it's a 3-to-1 randomization, standard of care, neoadjuvant, platinum-based neoadjuvant chemotherapy. So all of these patients are platinum eligible by definition from the entry criteria, and then within each of the subtype buckets, we're testing the combination, luminal papillary, atezo, erda. We have an agreement from Janssen to supply erdafitinib, which, as you know, targets the FGFR receptor, and FGFR is altered in a fairly high percentage of patients with luminal papillary, basal squamous, atezo plus tiragolumab, which is a TIGIT inhibitor, and there's a fair amount of data around TIGIT and bladder, and there's some nice data about the combination as well, and then atezo plus standard of care neoadjuvant chemotherapy and the non-luminal papillary and non-basal squamous. So it's important to understand that the neoadjuvant chemotherapy arm is not a control arm necessarily, but it gives us kind of a bit of a sanity check to just sort of make sure that we're seeing the responses that we would expect. And the beauty about it is everybody gets subtyped. So we'd have the subtype information, but in the neoadjuvant chemotherapy arm, but the numbers are going to be too small to render any kind of comparison statistically sound. And then the primary endpoint is pathologic tumor response, and you can sort of see the key for the biologic correlates in terms of circulating tumor DNA, urine circulating tumor DNA. We heard a nice talk yesterday from one of the potential sponsors, and then there's the potential for a radiomic evaluation as well. So, Josh, can you pick it back up, or would you like me to continue?
I can try. I hope sound is good quality.
Sounds not good quality. Okay. So the numbers actually, so there's 97 in each arm. I obviously talked about the comparator, decreases the sample size to something much more manageable, and I think a lot of us, hopefully all of us, feel like this is actually a better, I like this design a lot better. And obviously it gives us a shorter time to complete enrollment. This is just the statistical assumptions behind it that really hasn't changed. The predicted response rate for each of the subtypes is based upon data that we have from 13-14, looking at actually 3 different classifiers. This is based upon the data from the TCGA classifier. And then our subtyping partner is Tempus, and you heard a very nice presentation from them yesterday, and that actually is sort of moving along at a better pace now, and so They've ingested, so to speak, the TCGA classifier. They've been working with it. We're creating a validation cohort for their internal work before going to the FDA for an IDE. And then we've met a couple of times with the SWOGCTC. This is the Society of Urologic Oncology Clinical Trials Consortium. And we represented the revised study design to them at the AUA. And Sia is here. Sia informed me that they're on board with the redesign, and we're working with them to identify a medical oncologist and urologic oncologist who will sort of be the champion from CTC and actually work with us collaboratively on nailing down sort of all the fine little details of the protocol. So we've been given the go-ahead from CTP to start on protocol development, and realistically, probably activation timelines probably a year. If it could be 9 months, that'd be great, but probably more realistic, 12. So keep this on the radar screen for your platinum-eligible patients down the road. Any questions?
So do you think from GAP?
Leslie's next.
Hello. Yeah, so Parminder here. Josh, I was just following up with Lucky's remark. Do you think that the same bias which GAP is struggling with IO and platinum combination may come into play here as a barrier in future?
I mean, I definitely think every major trial, needs support, and we certainly need your support. But there's only one of the arms that gets IO and chemo. The other two arms would be getting IO and ERDA or multiple IO treatments with atezo and tiragolumab. So hopefully those are interesting enough and exciting enough that everyone will participate.
Yeah, Josh, you're in and out. So what Josh was pointing out, and I brought the schema back up, is there's really only one arm with IO chemo, right? And that's and I think conceptually there's, I mean, from all the people that we've talked to, and hopefully most of you in the room, there's a lot of enthusiasm for doing subtype-directed therapy and sort of testing these hypotheses of combination, whether it's IO or IO chemo, from a more perceived, more rational design based upon tumor biology. But there's going to be a lot of work to be done in terms of ramping up. This does not qualify as simple easy, so as we get closer to the ultimate rollout, we'll have our hands full in terms of doing a lot of preparation and education and I don't know, Abhishek, I'll go ahead. And I don't know, Sia, if you want to, I don't want to put you on the spot, if you want to say anything from the SWOGCTC standpoint. Okay, thanks. Abhishek?
Thanks, Seth. So I think the argument for chemo IO is well pointed. I would just like to point out that even though in the metastatic setting, the OS data and the PFS was negative due to various reasons, we did have a higher objective response rate with the combination compared to chemotherapy alone. And if you look at these trials and also Guru's trials, the primary endpoint is actually not OS or PFS, so I think we may still be heading towards a higher pathologic response rate, so I think that may be rational to put through as well.
Good point. I'll add to that in the basal squamous tumors, it's rational to think that both either chemotherapy or immunotherapy would be effective in that group. And I also I think we all have to be a little bit cautious of translating what we see in the locally advanced metastatic state to an earlier stage of disease. Sia.
Not much, just to say we have a lot of support for this at the SWOGCTC level. I think the redesigned trial is much more doable, and I think this concept's going to go over very well. It's a nimble trial. I think the standard of care is there. We can easily convince patients to randomize to this schema, so we're looking forward to it.
Yeah, I guess just. I'll show this a little bit later, but we did I realize this is sort of comparing apples to oranges, but in 10-11, we had 37 surgeons, I forget the number of sites, enroll 659 patients in just a little over 5.5 years. So as the surgeons, again, the entry point for this, we're going to have to step up with our medical oncology collaborators, but we can do this. All right, so we'll move on to the next.
Seth?
Yeah.
I've had
Sorry.
my hand up. This is Kathy, virtually.
Who's there?
It's Kathy Obey.
Oh, hi, Kathy. How are you? Kathy
Hi,
Albane, who is the head of the CTP. Are you there?
Yes, I'm there. I just wanted to add, that was a great summary, speaking on behalf of Clinical
Okay.
Trials Partnerships. Just so all your sites know, when we get closer to activation, there will be a site selection process, as we do for all CTP trials.
I heard site selection process. Kathy, unfortunately, the sort of internet is very slow and it comes in and out.
Raise site compensation and a simple site selection process.
Yeah.
Short version. Did you hear that?
No, maybe, would you do us a favor, if you can, put it in the chat, and we'll be able to manage it that way.
Okay.
Okay, but I think, Kathy, go ahead and do that. We'll come back to your question. I want to turn it over to Leslie Ballas to talk about her bladder preservation trial. Leslie.
Thank you so much. I am presenting an update on the bladder preservation with chemoradiotherapy or immunoradiotherapy after a clinically significant response to neoadjuvant chemotherapy. I'm presenting on behalf of my co-investigators, many of which are in the room, which is very exciting. And thank you to Tom and Seth for letting me present this update. So since we last discussed this at the fall meeting, there have been a couple of updates in terms of data that came out in abstract form at GU ASCO this January. Both Retain and Hoosier trials reported 41-month and 30-month updates in terms of their bladder preservation protocols in which they looked at patients who had a complete response after chemotherapy and then went on to either observation or immunotherapy. And I think what we learned, which was interesting, is that in the Retain study, of the 38 patients who went on to develop metastatic disease, 80% of those, or 8 out of 10, recurred with localized disease first, indicating and giving us even more data to say that there's a role for radiation in those patients who undergo neoadjuvant chemotherapy and then want to retain or preserve their bladder. And so, to further upon that, we're asking if we can improve on the 46%, almost 3.5-year bladder intact metastasis-free survival data from Retain. Can we hopefully prevent most of those metastases? And again, I think it really points to the fact that a lesson that we learned from SWOG 0219, that clinical T0 is not pathologic T0 and local therapy is still important, in addition to answering a question that is clinically important to our patients. So a reminder of the schema: we're taking patients who have clinical T2 to T4A and 0 muscle-invasive bladder cancer who up front opt for cystectomy. They get at least 3 cycles of cisplatin-based chemotherapy. Imaging and or cystoscopic response shows what looks like good clinical response, which we're defining as clinical T0 to T1. Then they would register on trial, meaning they would get their neoadjuvant chemo prior to registration. They would then undergo TURBT with template biopsies to, in fact, define a clinical T0, T1 response. Then they would be randomized to either radiotherapy plus atezolizumab or radiotherapy plus chemotherapy. Important is that if the patients do not have a clinically significant response, they would go on to standard of care cystectomy. And so this is the schema. When we did statistical analysis, it looks like we would need 112 patients per arm, with a 10% dropout rate. That turns out to be a total of 246 patients that will need to be randomized, which means that we probably have to register about 370 to 400 patients because some patients will probably fail with the template biopsies. And so further updates, we brought this to the Bladder Cancer Task Force March 17th. They were quite positive about it. A lot of discussion about whether or not we should be enrolling patients before neoadjuvant chemotherapy or after neoadjuvant chemotherapy, which is how our schema is set up. We are presenting actually next week just to readdress some of their questions regarding the schema or the protocol. So here it is, and I'm open for questions.
Leslie?
Thank you guys so much.
All right, good job, thank you. Yeah, you want to just read it first?
So here, these are comments from Kathy Elbain on the previous trial. Leslie, thanks very much. From CTP for the sites, there will be a site selection process with a simple questionnaire after the full protocol is approved. Also a robust site payment commensurate with other complex industry trials. Your committee members can also see more about CTP on page 10 of the spring meeting agenda booklet. Our website address is there if you have any questions. That's from Kathy Elbain. And then Dan had a question, when do we estimate the CTP full protocol will be approved? I don't know the answer to that.
Not sure. We have to write it first.
Probably late fall, I would say. Could you hear me?
Yeah.
Oh, it's Kathy again. Yeah, you're right. There's one little step yet, which is signing the contract, but that's just, I think, very close with the attorneys, and then the full tilt on the protocol development can start. So it goes through the usual process you're used to for NCI trials. There'll be a rapid review and then et cetera down the road, and it'll go back to the ERC for review and then to the FDA. So those steps ahead.
Yeah, thank you. I appreciate you pointing out the rather robust per patient reimbursement. Genentech has really stepped up. They recognize the importance of that and all the time and effort that all of us will be required to do to get these patients on trial. So the next is an update on the BCG unresponsive trial, and Scott is going to give us a brief update.
So I'll take about 2 minutes at a time. So this is urine responsive, randomized BCG unresponsive combination trial. So I won't go through the background, but this is a trial in development for FDA BCG unresponsive definition patients. Everyone knows the outlay of this entire space being really a space that's in development with single-arm phase 1s that are multiple out there. Within the NCTN, there's one other trial currently in this space, and it's accruing about 2.5 patients per month. And this is Pembro versus Pembro and intravesical gemcitabine, single-arm phase 2. This is from Mike Woods, looking at their expected accrual and the challenging accrual that they have been able to get to this point. So this is it's a difficult space to accrue in, I will say, at 3 patients a month. Currently, obviously, there's N803 in this space, which was not approved this week, as most bladder people in the room know. And then there's intravesical nadofaragene, both showing better than monotherapy IO responses. But even with these newer agents potentially coming online and being available, the goal that was presented, we did a 2-day CTPM, was that we wanted to try to develop a trial in this space that was high impact and I put in parentheses high accrual. It's a difficult population to accrue, but really to move beyond the single-arm phase 2 and do actually a randomized trial in this space. Most of us are utilizing gemdosi without any real prospective evidence to utilize gemdosi, and it would be nice that one of the goals is to definitely include gemdosi in a forthcoming trial. We wanted to look at combining accrual of CIS with pure papillary and then do sort of an event-free survival endpoint, especially with the papillary. And then there was thoughts about including a feeder for the BCG exposed. From what I'm understanding, there is a BCG exposed trial that's currently in development in one of the other groups. But our thought was to look at a sort of a two-part registration. And I'm just going to go to actually the second slide. This is the trial. The trial is for patients who have BCG unresponsive, CIS, or papillary, and then enroll those patients onto a 3 or 4 arm trial, with gemdosi being our standard of care, or de facto standard of care, nadofaragene, and then a combination. Obviously, we could all sit here and put 6, 7, 8 arms on a trial utilizing the phase 2 du jour intravesical agent or systemic agent, but in all reality, we have to realize that we're going to be able to accrue 3 to 5 patients a month. So we're going to have to not get too excited about the number of arms. Interestingly, the way that we really wanted to look at this in terms of defining futility would be to enroll 40 patients in each of the arms and then define futility based upon those CIS-only patients. So we have to meet a futility bar to continue that moving forward. At the same time, you can still enroll the papillary patients. And then ultimately, this could progress to a phase 3, but really the way we have it written, by the time you got, if the arms stayed open, by the time you got to 90 patients, you would probably already have enough patients just to be able to draw a conclusion about each of the arms and not really have to move to a phase 3. At least that's our thought. So this is where we're sitting right now. Obviously, we have nadofaragene here. I've got other slides that has N803 here. Nadofaragene is approved, although not currently available. And so this is where we're sitting. Questions?
So we just an update on Ferring. So Ferring is the company that's going to be marketing and the gene therapy nadofaragene, and we had an ad board with them, and their initial they've expressed a lot of enthusiasm, and so the next steps are to sort of continue that conversation and establish a pharma partnership. So we'll move on with an update with 1806, Dr. Singh.
Thank you so much. I'll be quick here. Let's see, so 1806. So we all know about the schema. Patients are, it's a phase 3 randomized trial versus chemoradiation atezolizumab for 6 months. And we had the stratification factors looking at T2, T3, chemo regimen, radiation field, and performance status. And so this is the key slide. I want to give a shout out to Scott Delacroix and his team. Mary Beth is also here for helping us push this very difficult perceived trial in the beginning and is accruing so well that we are hitting close to 10 patients a month. Our intended accrual was 8 to 12 a month. So today is 4 years from the launch, and I am hoping we'll be able to close the accrual by end of this year. We have 398 patients randomized already, and we have 417 registered for the trial. And so we should be able to wrap this up by end of the year and then move forward. There are a lot of interesting TM proposals going in. Our TM portion BIQ application was prioritized through SWOG and will be submitted for MRE11. NRG will lead that effort. And Josh is working hard on this with the TM group, so stay on for get more updates on that side. Few small updates. We want to push for in the last 60 patients more T3, T4 patients. We have also added a ctDNA blood draw in the amendment. The key problem that we are facing is that the patient is getting their standard of care lab done before coming in for that ctDNA visit. So I just want to remind the sites that at time point, please encourage your CRC to time the draw of the sample for the ctDNA with the standard of care labs. because at this point, there is no extra payment for that separate sample. It is just a lab draw, but we are collecting it. So make sure you time the draw of the sample with your standard of care lab, so then you don't end up with issues regarding who's paying for the draw at the site. I'm trying to put it through the amendment to make sure we have standard of care labs here, because you probably do get standard of care CBC before cystoscopy or any procedure. Just time that draw with that CBC or CMP for your procedure labs. So thank you so much. Any questions I can answer? Rick?
So we've been working for 5 or 6 years on the patient reimbursement for this trial for transportation, and so 2 weeks ago we got a disapproval. Unfortunately, I have failed you, this is my last meeting, so we need to move forward eventually on that, but it doesn't look like this is going to happen. The NCI has disapproved it. We're going to meet with them and try to understand the disapproval because it's a little confusing. So I just want to let everybody know that's not coming.
Thank you for your work on this, Rick. Thank you.
Yeah, Dr. Blinky gave a shout out yesterday at the plenary that this will be the largest chemoradiation therapy trial in I guess in any stage of bladder cancer ever conducted. So hats off to everybody in the room and those outside the room and online who've contributed to this. The accrual to this trial has just totally blown away all of our expectations, and I think it's a great opportunity to. Obviously, we'll learn a lot from it. There's a fantastic translational medicine program being developed in collaboration with NRG, and then our opportunity will be to figure out how to build on this. So hats off to everybody, and especially to Parminder for your leadership with the trial. So thank you. We're going to cruise through very quickly. I don't know if Robert Svatek or Rob, are you on the line? You see Rob? I don't see him. Okay, so you know that Prime's been closed for a while, and hats off to all of those amazing folks who've accrued to this trial and really made it happen. Close to 1,000 patients, and we've been working, and Kathy and the team been doing an amazing job with responding to the FDA's interest in seeing the data in the CIS population. They have that data. The FDA maintains a high level of interest in trying to figure out pathways to get new strains of BCG into the market. There's the potential for the Tokyo strain, but there's a lot of things that have to happen. We're working with JBL, who manufactures and distributes the Tokyo strain, and that's sort of where they have to get all their CMC together. So stay tuned on that. You can see the timelines there for completion of follow-up. So I'm very excited that the results of 1011 will be presented at ASCO as an oral presentation on Monday at ASCO. Obviously, the data are embargoed, so stay tuned on that one. And Tom, do you have any updates on 1314?
Go to the last slide. Thanks to everybody's support of 1314. The secondary manuscript looking at overall survival and progression-free survival is at European Neurology. We're working on some reviewer comments. David touched on yesterday a number of things. Great work by Amir Goldkorn and published in the Circulating Free DNA work. I think Jonathan Roseberg has something underway, Betsy, and others. So stay tuned, but a lot of great secondary analyses going on in that trial.
And the subtype papers we've revised it, submitted it, and hopefully just a few days away from sort of seeing what they have to say. So it's nice to see the downstream research and publication coming out of this important study. So we are going to go very quickly through our other NCTN trials, and we're going to leave hopefully about, well, not hopefully, we have a few minutes at the end to just briefly touch on two new concepts. So Guru, you want to come up real quick? Thanks.
So this is the phase 3 ambassador trial that's examining adjuvant pembrolizumab in muscle-invasive urothelial carcinoma. This study is led by Alliance with participation from ECOG and SWOG. So this is the design of the trial, a randomized phase 3 trial, pembrolizumab versus observation. It's slightly different from the other reported trials so far because it has co-primary endpoints of DFS, disease-free survival in intention to treat, as well as overall survival in the intention to treat. So not the PD-L1 targeted co-primary that was done in the CheckMate 274 trial. So there are correlative studies that have been described before, as you can expect. And ctDNA was added recently for MRD. There are quality of life correlatives. So this study is actually closed since the adjuvant nivolumab became approved. Luckily, we had accrued nearly all the targeted 739. So 702 patients had been accrued at that point when nivolumab was approved. So nearly did meet the target of 739, and it is believed that we will have the endpoint, the events necessary to make this a meaningful study. As you can see, Alliance has the highest number of accruals. The study is led by Alliance. SWOG is second. Now, I will point out that I personally put a lot of patients on this, but this was done at Dana-Farber, and it actually went to Alliance and not SWOG, so, which I tried to get them to change it. Wouldn't happen. And then, of course, we're waiting for events on this study, event-free survival and overall survival, the co-primary endpoints. And according to Andrea Apollo, hopefully this is going to happen soon this year. Let's see.
Yep.
And that's it.
Great. Thank you. I guess this is Shilpa's yeah, Shilpa, are you online? This is just an update of the Alliance trial. Gopa Iyer's study.
I don't see her.
Okay, so Shilpa and Amit Gupta are our SWOG champions. You can see the accrual down to the right, and that trial's been. Oh, sorry, I'm kind of running on my. I can see it perfectly on my computer. Yeah. Oh, sorry.
Got it. That's the slide there.
Oh, go ahead.
What's up now?
Yeah. Anyway, so keep trucking away. This is a really nice trial. It's another sort of, again, in the bladder preservation space, it's patients who are platinum eligible getting GC neoadjuvant chemotherapy. Everybody gets MSK impact if you have one of those DDR gene alterations and you have a complete clinical response to the chemotherapy or just residual CIS, you can go into observation. And then if you don't meet that, then it's either cystectomy or radiation. And so the next trial, Mark Tyson, Chethan, are you here? Mark was here. Yeah, go ahead. You can use the microphone back there.
Yeah, just a quick update on A03, 1803. Was kind of provided a little bit earlier by Dr. Delacroix, but it's accruing well. This is, as you recall, a single-arm open-label phase 2 involving intravesical gemcitabine and combination IO therapy. Next slide. There's 160 planned. We're about 93 as of last week, and SWOG's contributed 34.
Yeah, we just recently got this activated, put 2 patients on right away. I think for those of us that are accustomed to seeing these patients and having trials open, this has not been as challenging to put patients on as I thought it would be with a systemic IO agent. So let's try to help this get to the finish line. And I guess Josh is our study champion. You want to?
He asked me to present because of the.
Okay,
yeah.
Parminder, thank you.
So I'm just updating this for Josh here, EA 8185 Monica Joshi chemoradiation trial, very similar to S1806, except that this includes patients with lymph node positive disease, and S1806 was without lymph nodes. So similar design, chemoradiation plus Durva versus chemoradiation. Radiosensitizers are similar, cis, 5-FU gemcitabine. And so the trial had been struggling to accrue because of this rare situation of having lymph node positive disease and they want bladder preservation. Accrual, they have accrued 9 patients and the 10th one just screened, but they need your support to ramp up this accrual to get it to their target. Thank you.
Hey, Ed, are you on the line?
Yeah, I'm here. Can you hear me?
Great. Thanks. Ed Yen, from medical oncologist from Baylor, who's our study champion for Shilpa's trial.
Yes, just a really quick update. Thank you, Seth. So this is the main CAT trial, or the A032001 trial. This is a phase 3, just as a quick update, phase 3 trial looking at maintenance of avelumab plus or minus cabozantinib. It's pretty flexible, upper tract and bladder patients are allowed, and 3 diseases allowed, mixed histology is allowed. Patients can get cisplatin or carboplatin. They have to have had either stable disease or a response, and they're randomized 1-to-1 to avelumab plus or minus cabozantinib. The target accrual is 654. This trial has been open since March of 2022, and so far I think there's about 29 patients. Primary endpoint is survival. I'm going to skip through this slide. Next slide, please. Okay, and so in terms of accrual, again, target accrual is about 654. Currently, about 29 patients have been enrolled. So that means that overall, maybe about 2 patients a month have been sort of the rate. Right now, I think 19 patients have been accrued by Alliance. For SWOG, about 5. So please consider opening this trial at your site. Overall, there's been a lot of sort of efforts to try to publicize and increase accrual. There was a webinar that was held by Shilpa in November. There's another one planned in May. It's been advertised on BCAN. It'll be presented at ASCO as a tip, and it's been submitted at ESMO as a tip as well. CCTG activated since October, and there's been another amendment that's ready for submission to be basically making it more flexible. There's also talks about opening it with EORTC, so that's pretty much it.
I would just say, I think this is Tom, in Colorado, we had trouble opening because of the bone scan requirement. I passed that on to Shilpa, but that's kept us from opening.
Gotcha.
Yeah, we can.
Thank you.
We can go to the next one.
Dan's online.
No, the study's closed, so, yeah. So this is the new upper tract trial from ECOG Akron. Do you want to talk? You want to?
Yeah, happy to
great.
present a quick update on the trial. So this trial is building on the prior neoadjuvant upper tract trial from ECOG. I think here we have the schema for the previous trial where patients who are cisplatin eligible underwent accelerated MBAC followed by NEFU. And it showed approximately 14% pathologic complete response rate, which is deemed worthy of further investigation. I think next slide is the schema. So the trial has 2 cohorts. One is the cisplatin eligible cohort. That is the phase 3 part of the trial, the randomized part. So patients with high-grade upper tract urothelial carcinoma will be randomized to receive accelerated MBAC and durvalumab, again, chemo-IO approach, building on the prior study, versus just neoadjuvant chemotherapy. And there is a separate cisplatin ineligible cohort, which is interestingly evaluating gemcitabine with durvalumab without the platinum, because the contribution of platinum was considered dubious. The total enrollment for the trial is around 220 patients for the cisplatin eligible cohort and around 25 patients for the phase 2 cisplatin ineligible cohort. I think there's a later slide for updates in terms of enrollments. So some of the improvements some of the updates in the trial that have actually helped the accrual has been increase in the timeline from diagnosis to registration and randomization. It was increased to 3 months. The trial was initially activated in the COVID timeframe, so I think over last year we've had some uptake in enrollments. I think we have had 9 new patients so this past year, so it is encouraging. It's active at it's in the process of approval at a lot of other sites, so really appreciate any support opening and enrolling this trial. Thank you.
So as I'm just looking at this, I guess Guru, this would overlap a little bit, right? With the gap? Oh, sorry. Excuse me. That's right. Yep. Okay. Let me just talk briefly about the bridge study. This is the Max Cates from Hopkins is the PI, another ECOG-ACRIN trial. This is essentially a mirror image to 1602, two-arm study, gemdosi, and then TICE BCG according to the SWOG protocol, straight up one-to-one randomization, almost identical size trial, a little bit smaller. That got activated in December, and I would encourage us all to support it. This, this is a great way to boost up accruals, both at your local site and obviously for us here in the GU committee. And this is the last slide, and then Parminder and Mamta, if you have a stick, kind of bring it up. You want to talk about this, the modern?
Yeah, I think this is a very interesting trial. I'm not going to say too much about it. It's directed by ctDNA, sort of in this setting. I think that's very interesting. It'll direct therapy, and sort of more to come on this. But I think the design we felt very favorable about in SWOG.
And did you have any idea from Matt when that's going to be activated?
I think they're getting close. Yeah, they were pushing protocol completion, I think, is done and so forth.
Yeah. Okay, so we have, I'll tell you, we have 10 minutes left.
10 minutes left? Okay.
Yep.
Done a quarter after?
Yep. Yeah. Well, we had an hour and 15 minutes, so we want to stay on time. So we're going to do two short presentations.
This is mine, yeah. Okay.
Oh, you got them, okay.
So should I presenter mode?
Yeah, sure.
Perfect. Thank you so much. I was just talking to Sid yesterday. This is my 10th year here. So started in 13, now 23, so we'll keep going. So this is a follow-up presentation to Nick Vogelstein's symposium we did last year. So please keep the discussion confidential. It is about what next after 1806. To remind folks, the 1806 was geared towards defining the definitive therapy, which is chemoradiation. So we were trying to add and improve definitive therapy. And so next was to look for questions, what should come next. So then I followed up my conversations with Rick, and he alluded to three key elements which go in his mind when we are talking about bladder preservation, which is the cancer question, the bladder question, and the cost question. And within those three elements, which I kind of got attracted to, is the word metastases, which is of concern to him. So I kind of started building on it and looking at the data, which we already know, that there are patients after definitive therapy who die from their cancer, and they're dying from metastases. So 8710, we saw that 43% patients will die at 5 years, even after radical cystectomy. And we know that those patients are driven by patients who are not responding to chemotherapy in the beginning, as they have residual disease at time of radical cystectomy. And so we know that even in contemporary trials now with adjuvant immunotherapy, still there is a high burden of distant metastases. There are close to 1/3 of patients, even after immunotherapy, have distant metastases. And so then what can we do about this? And in chemoradiation, if we pick chemoradiation as definitive therapy, then again we have close to 30% patients who are having distant metastases post-definitive chemoradiation. So what is happening in advanced disease setting, which we can bring it into this setting, is the new era of ADCCs combined with IO therapy. I have deleted a lot of slides here, but I was trying to show that IO and chemo in general, IMvigor and Keynote trials have failed to show any improvement. So, but then we have these new class of drugs which are showing not seen before kind of activity in this space when we combine them with immunotherapy, as we saw with EV103 with a response rate of 64%, and also with SG in second line having up to 20% patients having CR rates. So there is something to this class of drug which when combined with IO is showing improvement. So can we bring this to to the bladder preservation setting. So again, this was all the table showing all the data from all these trials. So can we improve the systemic recurrence risk in bladder cancer post-definitive RT? So that's a question I started focusing on. And so we kind of put together a small group after the Nick Vogelsang Symposium to discuss ideas, and this is coming out of that group. Is a proposal of phase 3 randomized trial of adjuvant ADCC plus Pembro after CRT for high-risk bladder cancer. We call it EPIC trial. So the feedback which we are requesting from the group today are three. One is the schema, second is the eligibility, and third is the endpoint. So I'll just try to focus on, I'm going to show you two schemas, and with show of hand, you can tell us which schema looks more attractive. This is the first one. Patients are 9 weeks post-CRT, so anybody who got chemoradiation for their bladder cancer, so it's an open eligibility, pragmatic design, can be randomized within 9 to 12 weeks of finishing their chemoradiation to receive ADCC plus Pembro as 4 cycles of adjuvant chemoimmunotherapy, or observation, which is standard of care, and then look for endpoints. What the attractive points about this design is a simple design, easy to explain to the patient whether you get therapy, you don't get the therapy. There are new contemporary medications in the option, and then there's a limited commitment to the trial, only 4 cycles. The other schema is you do the same, receive chemoradiation, you can be randomized to ADCC Pembro versus Pembro. So we are making it more attractive by adding Pembro in the standard of care arm for a year, and then we look for endpoints. So with show of hand, do you think adjuvant therapy in bladder sparing is an interest to the group? Just by show of hand. From patient advocates, Darren and Rick, what do you think? So we got a thumbs up there. So which study design is more appealing to you as a group? Group scheme A or B? So A, which is just 4 cycles. So we see around 5, 6, 8. Okay. And then B is 1 year worth of IO therapy on a trial. So less interest to Monty.
A lot of people didn't vote.
Okay, so we'll refine this. So because we want to pick a design which is more.
If I'm the pharma sponsor, I want you to give it for a year.
So this is 1 year worth Pembro in the one arm, and just 4 cycles of chemoradiation versus 1 year Pembro. So we got 4 people supporting the B and 8 for A. Okay. Now the next question, the eligibility part. All patients, should we have all patients who have received definitive chemoradiation as 55 or 64 gray as guideline-directed radiation therapy, or should we use only 64? We use 64 in 1806.
So unfortunately, I want to make sure we get time for the last presentation. So
1 more minute. So we'll end with this slide then. So, because this is the key part. So this was a key input from the group discussion we had. Should we select high-risk patient, or should we select all comers? High risk means patients who are ctDNA positive after their chemoradiation, or they had large tumor or high-risk disease to begin with. This will limit my enrollment to 5 patients a month based on 1806 criteria, because 1806 was all comers. But if you think that will make it more attractive, or we should keep it for all comers. That's a very important point so that we can get some estimates for your accrual.
So come to the bladder calls. And we'll get into this in a lot of detail. Thanks for presenting that.
Thank you.
Very, very clever.
Thank you.
One last short presentation, and then we'll turn it over to Kidney.
Sorry, this is not the right presentation, but we'll get through it. I wanted to thank Dan Petrolak, as well as Parminder, as well as the chairs of the bladder team for helping to talk about this concept. So this is a concept that we presented earlier when we were discussing pragmatic trials, looking at defining optimal second-line sequencing for patients that have gotten EV plus Pembro in the first-line setting. And I apologize because these are not the right slides, but we have been discussing adjustments to this protocol concept. And so the concept that we're actually proposing is looking at sacituzumab govitecan versus sacituzumab govitecan plus carboplatin. It would be in patients that have been treated with EV plus Pembro in the first-line setting. And we can talk through some of the specifics of the details of that. But again, the idea would be to define the second-line treatment in sequencing as sacituzumab govitecan, and then looking at whether the addition of carboplatin would be beneficial.
So for the top part of this, rather than gem carbo, it would be
It would be
sassy
sassy
carbo.
carbo, yeah, sorry about that. So anyways, I will be happy to discuss this with you guys offline or at the bladder calls. But so we've been talking about doing a
So the question
safety
was, is there
lead-in.
any phase 1 data?
So there is some data of cis plus sacituzumab govitecan, but there is not with carbo. So we talked about doing a safety lead-in. So this is stuff that's been generated at this meeting, so we'll discuss further at the bladder call, but thank you.
Okay, thanks, everybody. That wraps up bladder. I'll turn it over to Brian and Ulka online.
Yeah. All right. So welcome today to the renal subcommittee. Just a second. Okay. Good afternoon, everyone, and we'll go ahead and get started with the kidney session for today's GU committee meeting.
Right.
And we have some exciting stuff to present to you, as well as some updates on our existing studies, which one of which we already presented and talked about before. Okay, all right, so it's advancing. So advanced subcommittee will start with advanced renal and then turn it over to Brian, who will be doing localized renal. So this is starting with our SWOG 1931 or PROBE trial. This is a phase 3 study of immunotherapy-based combination therapy with or without cytoreductive nephrectomy for metastatic renal cell carcinoma. This is an ongoing trial, and we are actively accruing study design really quickly, RCC with primary tumor and metastases, and then any of the 5 FDA-approved regimens of immunotherapy-based combinations, so Ipi-Nivo, Pembro, Axiavelumab, and Cabo-Nivo and Len-Pembro are allowed. In addition, Pembro can be given every 6 weeks if that is your institutional policy to schedule things that way. Even that is allowed. Patients can have started on the immunotherapy regimen even before they get registered and randomized, so up to 12 prior weeks of therapy. But then within the 10 to 14 weeks, if patients who are responding and or having stable disease, even pseudoprogression, you can discuss with me and potentially plan on accruing if the patient is clinically doing okay. And then they get randomized to either nephrectomy or continuing on with the immune-based regimen. Now, the continuation, the standard arm here is continuing the immune-based regimen. And then adding the nephrectomy is what is the additional piece of the study, because with the Carmina trial results, we know that nephrectomy does not add anything with sunitinib-based therapy, but with the immune-based therapy, it's still an open question. Okay, so these are how many sites are open as of now, and NCORP's approved, and accrual to date has been 86 as of April, end of April. So this is very hot off the press data, but our accrual target is 364. So please, with all the centers open, if each center could put 1 or 2 patients on, we would be done in no time. So please think about this study and try to get patients on. And if you need any help with it, both Dr. Kim, Hyun Kim, and I are available for any questions, or if you need any help in talking to the patient, we have a patient-based video. We also have our patient advocate who will be happy to discuss things with the patient if that's what you need. Here is our randomization accrual, and this is, of course, the actual number of patients randomized is 56 as compared to the total accrual, which is everybody who is registered so far. So we have some attrition, of course, as patients get registered, but may or may not get randomized because their disease is progressing or they're no longer nephrectomy candidates. Thanks to our star accruers, huge thanks. And, these are people who have put 3 or 4 patients I'm going to sort of make a mention. Pedro sort of tops the list, no matter which institution he's at. In Louisiana, he was accruing, and now he's in Cleveland Clinic, and he's already started accruing. Arnab from UAB is also doing a great job. Thank you, Arnab. And then Ben Lee and Dan Morera, both urologists who are PIs, are doing a good job accruing. Thank you. Suzanne Cole from UT Southwestern, of course, has always been a wonderful supporter of SWOG, and I thank her again. And Alejandro Sanchez is doing a great job. He's at Huntsman, and thank you. And Shuchi, of course, at both institutions, again, University of Cincinnati, she had great accrual for us, and now at UC Davis also. So thanks, and I will be highlighting some more accruers. There are some others who are pretty close to these guys who are coming on board. So thank you very much. Okay, this is our accrual pattern, and we want to be around that 4 per month level, so which is where we are getting there. Of course, COVID held us up. We opened right in 2020, which is, so we had 2 COVID years, but now that all these centers are open, just keep looking for those patients. Thank you. And then I just wanted to put this reminder of all 5 regimens that are currently FDA approved are okay to use. Now the pre-therapy, pre-systemic therapy, just to make it easy on you guys, so you don't have to do repeat scans, etc., up to 90 days prior to starting systemic therapy, those scans are allowed. So you have a pretty wide time window there in terms of having disease where you're putting patients on therapy. And of course, as I said, we have the patient education video, we have CME accredited program available, a presentation that is targeted on probe, but also about the basic landscape of cytoreductive nephrectomy in kidney cancer, with some case presentations to give you an idea of which cases would be eligible. And then, so bottom line, I would say prioritize the study for synchronous metastatic disease patients. Please, please, we need the patients. And this is a patient population that I want to highlight is not doing very well. Median survival of 26 months with Ipi/Nivo as compared to 48 plus months for all comers. So already these patients are having an overall survival and outcome of about half of what post-nephrectomy patients do. So, patients who've had a nephrectomy and then a year or so later have relapsed. So that is a different patient population than the patients who present with the big primary and metastatic disease. So please keep that in mind. You're making a big difference. No pharmaceutical company will conduct this study. So SWOG has taken on the mantle. So thank you. And there is our emails if you want to contact us for any questions or concerns. Thank you. Okay, so please support SWOG 1931 or the PROBE trial. All right, and then I'm going to turn it over to Ben so he can present PAPMET-2, which is a papillary kidney cancer study.
Well, thanks everyone for letting me virtually be here for the meeting. So let's talk about PAPMET-2. So as a reminder, here's the study schema. Let me see if I can move that. So this is for patients that have metastatic papillary kidney cancer. They have to have measurable disease. As a general rule, no prior therapy, although they can have had, I say no prior therapy for metastatic disease, but they can have been treated in the adjuvant setting. Patients get randomized to standard of care cabozantinib per the SWOG 1500 clinical trial, or the investigational arm is cabozantinib plus atezolizumab with the primary endpoint of progression-free survival. We are planning to enroll 200 patients. The key eligibility criteria include histologic confirmation of papillary kidney cancer. We're not making a designation based on type 1 or type 2. Again, no prior lines for metastatic disease. It does include up to Zubrod/ECOG 2. And the exclusion include, again, they can have had immune therapy with pembro in the adjuvant setting, but it must have been discontinued at least 6 months prior to enrollment, and no clinically significant autoimmune disease. So where do we stand in terms of enrollment? So I have a couple of different rows here. So if you look at the projected versus what I call adjusted, projected just means we're anticipating 4 patients per month. And every trial has a lag period at the beginning where sites are getting open. So that's what sort of the projected, but adjusting for that is. If you look at the total, the first patient was enrolled in March, so we're a number of patients behind what we were originally projecting. And this is relatively worrisome, but what I'm more concerned about is the sites. This is really sort of the first hurdle for any clinical trial. We have to get it open so that it's available for patients. And if we look at the total number of sites and then also the number of NCORE sites, it's still open at a relatively limited number of places. I'm reviewing these monthly reports from SWOG, and I've tried to pick out those academic sites that have it open. I apologize if I've missed one of your sites. Please let me know, and I will correct that. But as you can see, we're opening at a reasonable number of NCORE sites, but the academic sites are definitely lagging behind. We do have an ECOG champion at Johns Hopkins with Yasser Ged. So we're still very much in the opening phase, trying to get places open. I'm just somewhat worried about the rapidity or lack of rapidity of getting it open in a number of places. I do want to express a lot of congratulations to a couple of NCORE investigators who have enrolled the first couple of patients. Very grateful for their participation. Looking back at the success of SWOG 1500, approximately 20% of the patients were enrolled through NCORE sites. So they're a very critical partner for the success of this rare cancer trial. Approximately about 20% of the total patients enrolled came through the Canadian Cooperative Group or Cancer Consortium mechanism. We recently heard back from their group, and unfortunately, they are not going to be participating with this particular trial. So again, considering the significant contribution that they had for SWOG 1500, that puts a greater responsibility on all of us to enroll even more patients. So there are a number of barriers. So as all of us know, a lot of our centers are contracting or restricting the number of trials in our clinical trial portfolio as a consequence of COVID. And this being a rare cancer, that certainly is one barrier. When I anecdotally visit with a number of people, the very first sort of clinical trials that oftentimes are cut out of the portfolio is rare cancer trials. So that poses a significant challenge. There are a few competing studies, but not many. Some institutions like MD Anderson Center or Memorial Sloan Kettering have some IITs that are competing. The Stellar 304, a national basket trial, is competing somewhat. So there are multiple histologies, non-clear cell histologies included in Stellar, papillary and classified in translocation. But notably, it excludes chromophobe, renal medullary, and collecting ducts. So again, the bulk of Stellar is going to be papillary with a decent amount of contribution I anticipate from unclassified. So that's potentially an issue, especially in the context of centers not wanting to open multiple, I anticipate not wanting to open multiple trials for rare cancers. Papillary kidney cancer is the only histology allowed in SAMHSA, so that's also somewhat competing. And then again, as I mentioned before, the Canadian Cancer Society has elected not to participate.
In the interest of time, we do have to move. I agree.
All right, fair enough. So let me just finish by saying this. So in terms of a strategy of how do we work through this, it's really essential that each of our sites really reaches out to the regional community to try and encourage a lot of referrals for papillary kidney cancer moving towards our sites, because we have to realize there will be less participation with this rare clinical trial than other cancer types. I'm happy to talk to any of you about other strategies that we may have, but thank you again for all of your support.
So the next study on the agenda to present is the Alliance Pedigree study, which is ipi-nivo followed by nivolumab versus VEGF-TKI cabozantinib with nivolumab. So nivo versus cabo-nivo in metastatic untreated kidney cancer. So here is the study design. These are, again, untreated patients, ipi-nivo only therapy. And then after 3 months, depending on response, if they're progression, then they go on to just get cabo standard therapy. And if they are either PR or stable disease, then they get nivo versus cabo-nivo. Now, this study does compete with PROBE. However, it has it's near its accrual target, as well as this is an alliance-led study, which SWOG has supported already plentifully. And I would hope that people would prioritize PROBE for the patients who present with synchronous kidney mass and metastatic disease, as compared to the patients who've already had prior nephrectomy could potentially go on this for metastatic disease. Again, overall survival, similar to PROBE, overall survival is their primary endpoint. And so far, they have 877 patients already enrolled, about 20 to 30 patients per month since their opening, and about 10 to 12% are from SWOG. And that number has probably increased by now, after we got these accrual numbers. So randomization is a little bit slower than what they anticipated. They're looking at about 48% of their patients are going on to get randomized. So, depending on what you see, ipi-nivo, about 52% of the patients are progressing, or half of them are progressing. So keep that in mind. I mean, I think VEGF-TKI and IO combination is something probably that most of us would prefer to use upfront. But if you are using ipi-nivo and in the already performed nephrectomy patients, then this is the study potentially. So they've increased their sample size by about 10%, and that takes them to 1175 target sample size. But they're at 880 or so. So I think by the end of the year, we're anticipating this study will be done. So just keep that in mind. They have noticed some dropout for toxicity or death with ipi-nivo. They did do a deep dive, and what was noted is that majority of these were related to disease and not related to treatment. So at least that was reassuring, but ipi-nivo, they did have a number of death rates reported up front on the study, which led to this concern. They have an investigator meeting that will be held in the fall. All right, and then I'm going to turn it over to Pedro Barata to talk about our exciting new concept in advanced kidney cancer, which we had so far named BioFront, but we're really looking for catchy names for this study, and this may have been my limited imagination, but we are absolutely open to ideas. If you come up with a new catchy name, we're willing to hear that. Pedro, are you ready? Do you want to share screen do you want to show your slides, or do you want me to advance?
Thank you. Okay, it's fine if you
Okay.
wanted to advance,
Sure.
we can go.
Sure.
Thank you so much.
Okay. All right. Ready?
All right. Perfect. All right. Thank you, everybody, staying here for the kidney session, and thank you for the opportunity. So I think for those of us who were here yesterday, fantastic workshop, once again, microbiome workshop. And so we did see some of these slides. So I'm going to go through it. It's a concept that the renal group is putting together. So we've seen emergence data, right? Showing association of antibiotic use with inferior outcomes for patients with solid tumors. And in here you have some data in lung cancer, also in kidney cancer. You have this, time to event curves at the bottom, and also the response rate on the right, basically showing us that, there's definitely an association with the use of antibiotics and worse outcomes. Next slide. There you go. At the same time, as we start seeing, emergence of studies in microbiome, we do seem to see an association between specific bacterial species and an improved activity, with response to systemic therapies, including specifically immunotherapy. Here at the bottom, you have Echinacea, you have Enterococcus, but also I'll highlight Clostridium species seem to be associated with improved responses. Next slide. So with that in mind, I would like to spend a slide or two just highlighting the CBM 588. Is actually a commercially available live biotherapeutic product that contains Clostridium butyricum. And so this bacteria produces short-chain fatty acids, particularly butyric acid, and actually has the ability to modulate the composition of the GI microflora. I'll show that in the next slide. Basically, it's produced, Ulka, can we go back just once? Yeah, thank you. So it's actually manufactured by a Japanese company, Amerisian, and it basically manufactured it for Ozel in US. And so basically, it has the ability to increase the fecal short-chain fatty acids, and that seemed to be associated with outcomes in patients with RCC. I'll show you that in a slide or two. And so with that said, next slide. Here's a little bit more of the specific properties of CBM 588 that we think it's a good idea to leverage it further. So as I said, it's actually manufactured and clinically used in Japan for a long time to treat and prevent GI symptoms, including diarrhea and other disorders. So it has a tons of clinical experience with this product. As a butyric acid producer, it actually has the ability to restore the gut microbiota and mucosal function. So actually changes the gut microbiome, including bifidobacteria. It also has an effect in regulating the mucosal immunity, if you will. And next slide. And I think we can see that better in this schema, which is a fantastic paper. It's a little bit complex, but you can see the different components of the proposed mechanism of action for CBM 588 there. And that's basically the rationale by which we can see an augmented activity with checkpoint inhibitors, at least in lung and kidney cancer. So that's what we know, and I would take a second here to highlight really the clinical development of this product, and I have to highlight Monty Paul and his outstanding group. They've really been pioneers in developing this concept, or how to leverage microbiome in RCC specifically. I think this paper is very rightful so, very popular at this point, because it was basically a proof of concept study by Nasli, Monty, and the entire group at City of Hope. And basically what they did, next slide, basically what they did is in a proof of concept setting, they basically tested the combination of CBM 588 to the backbone Ipi/Nivo, which is a standard of care for patients with advanced renal cell carcinoma. At that time, they considered biological endpoints. The correlatives of this study are pretty strong. Here was the change in bifidobacterium, but what is interesting to note in the next slide is actually the outcomes of patients enrolled in this proof of concept study was 30 patients. You see there, basically, I'll highlight the more mature PFS data on the left. See a huge difference, right? Of course, small sample size, but nonetheless, patients are definitely doing way better. They were offered CBM 588 with Ipi/Nivo compared to the standard of care, Ipi/Nivo alone. And so, so these data was very provocative. It landed in a very high impact factor journal as a consequence of that, and we start talking a lot about it. Here's a little bit more of the clinical efficacy endpoints here. You see the response rate there and the waterfall plot on the right. I think the message is the same. You basically see an improvement of the response rate for patients receiving the CBM 588 compared to the standard of care Ipi/Nivo, and the same is true for any degree of tumor shrinkage. Next slide. And so with that said, I just think another second to say that in following these data, Monty, Nasli, and the group did conduct a second proof of concept study, this time with an IO TKI. As you guys know, following Ipi/Nivo, we now have a number of IO-based approaches, including cabozantinib and nivolumab combination, as considered also based on checkmate 9ER, another gold standard for this patient population. So the City of Hope group went ahead and basically explored the same concept of combining CBM-588 with cabo-nivo. The results of this trial, we have not seen them publicly. They've been submitted to ASCO. Actually, we're going to have a very nice presentation at ASCO in 2 weeks. And of course, the data is embargoed for that reason. And I'm going to share the data with you. But basically, it's in line with what we would expect. And I think it would, support our excitement about the investigation of microbiome in this particular setting. So with that said, we move forward and we put a larger confirmatory study, if you will, and here's the proposed schema for the phase 3 trial leveraging on CBM-588 combined with a standard of care cabozantinib and nivolumab. So patients with RCC in a clear cell component previously untreated would be randomized in 1-to-1 fashion to cabo-nivo plus minus CBM-588. I don't have the placebo in there, but it's something we are considering. There's a possibility to do a placebo in the cabo-nivo arm. And the primary endpoint would be progression-free survival. We have discussed a few stratification factors. I think IMDC would be one of them. Next slide. So here's, with the help of Kathy, thank you, we had a few assumptions, statistical assumptions. I think it's legit to say that in this space we've considered a difference in PFS of 4 months as to be clinical meaningful or more. And as you can see there, we were around a ballpark of 850 to 900 or so patients continuing to drop out or failure rate, if you will, for this confirmatory phase 3 trial. Next slide. And so as a summary, and I think as our last slide, we think this is an easy, less toxic and way of improved clinical outcomes. I should have highlighted perhaps more some of the data that come out of Monty's group is actually the absence of any safety concerns whatsoever, and that's, I think it's a very important point. It's a very easy study to accrue. I think it's an appealing trial to patients. I mean, also appealing trial to providers, I would argue. I mean, the packed room yesterday actually is confirmation of that, right? We all want to know a lot more about this. And I think is also attractive to patient advocacy groups. I think we have the chance to be the first in the cooperative group mechanisms to evaluate microbiome intervention in a larger setting. And the company, Ozel, is actually has an adequate, manufactured product supply of the product and also willing to help us with a placebo for the control. I think we can go beyond RCC as a way to leverage microbiome across multiple tumor types, and where immune checkpoint inhibitors are considered gold standard. And so I think in this setting, I think SWOG has a chance to lead the way in the microbiome therapy in combination with immune checkpoint inhibition in oncology. And I'm happy to take any questions, and thank you for the opportunity.
Thank you, and thanks, Pedro. And I would like to open this up for questions or, comments on this study design, if anyone has any concerns, and then also about probe. And we have one more study that we missed that we are going to quickly present, if that's okay. And that was the radical study. Okay, so radical is a study of.
We have a couple of questions here in the audience.
Okay, good, but let me just finish. Radical is a study that is in patients with bone metastases. Mamta, if you want to say 2 words, if you're there, we just appreciate. Sorry, I can't.
Yep, I'm here. I'll just be very quick. Just a reminder, this is a study that requires you to just have 1 or more bone lesions that have been untreated. And it randomizes patients to receive radium-223 plus cabozantinib versus cabozantinib alone. We have currently accrued 49 patients on this trial, 9 from SWOG. It has been activated since 2019, so it could really use your help by, we've put patients on this at UC Davis, but we'd love to see more sites from SWOG on this. So that's it. Thanks.
Mamta, and can you clarify that prior therapy is allowed?
Prior therapy is allowed, prior immune checkpoint inhibitor is allowed, prior anything but cabozantinib is allowed.
So if you're using second-line cabo in your patients, think of opening this study. This will be cabo plus radium. Okay, now let's go back to questions. I'm just going to go back to our new study design.
So this is Kathy, if you don't
Yeah.
recognize the voice, Ilka.
Yeah.
So I'm really enthusiastic about Pedro's and yours study. Things are moving fast, and I think there's opportunities for innovative trajectories to the NCI, and all this discussion, especially if some of this data is going to be available for other disease sites at ASCO, I think it would be really great for us to propose another cohort, another disease cohort with your trial and go across disease committees. So I think
That's
we
a
should be ready to
fabulous-
pounce on that. I'm just throwing that out there.
Yeah, yeah. I mean, I wonder if we should incorporate bladder and just do a combined study with both tumor types. But yeah, I mean, that opportunity just came across. So we'll have to look more into the details of that. But that's a wonderful idea, Kathy, to sort of apply it across multiple trials. And with more and more staffing constraints, if you can open one study that impacts 2 disease types, I mean, that I feel would be attractive, at least in our institution. I don't know if anyone else has comments or input.
I can see the room, okay, and everybody's saying yes, so.
Yes, okay. All right, and show of hands, does anyone have an issue with placebo? Because I think with a live biotherapeutic like that, I think it probably is a good idea to be a double-blind randomized trial, but
Yeah.
we'd just like to hear from anybody.
Yeah, I think it seems the room is calm.
Okay.
And we
So
have
people are
Shushi.
okay with
Let
that,
me.
right? Okay.
Yeah, we have a couple
It's
of
an oral
questions here.
placebo anyway, but.
Oh, Shushi.
Yeah, I just have a quick comment. So, because there's data with Ipi-Nivo and now with Cabo-Nivo, any reason to not allow people to use Ipi-Nivo and incorporate that in, because many people have a preference for that combination as well. So any reason to not have Ipi-Nivo as well as Cabo-Nivo? Or
Yeah, so excellent point. And we truly did consider that, Shuchi, is whether to do both, allow either or regimens, since we have safety data with both.
Right.
The one slight concern is there may be a competing Ipi-Nivo based trial in the NCTN. So our slight concern was, whether that would be a concern from the task force and as we took it to GEO steering committee. But otherwise, I agree with you. It would be important. We'd of course have to stratify. It might increase the numbers a little bit, but we'll take that under discussion and
I think it'll
probably get input from task force on that too.
it might make it a little bit less restrictive, just.
Yeah.
Sure. Yeah. No, that
Okay.
is
Kevin.
Great presentation, Evan Hall, Fred Hutch Cancer Center. I just echoing the Ipi-Nivo, I think, we feel like this would be working with immune mechanism. There's, obviously we can't speak to the Nivo-Cabo data, which we'll see soon, but I do think it would be nice to include that. Many patients are reluctant for TKIs, and, just the mechanism of action. And it seems like maybe you could have a smaller study because the PFS is anticipated to be much lower in the IO group. And I think pedigree seems to have shown that you can still accrue to Ipi-Nivo reasonably well in the first line setting. So just some comments, but I think great presentation.
Yeah, I think the one concern about Ipi-Nivo is that, maybe PFS goes away as an endpoint because, PFS was never quite significantly better with Ipi-Nivo now. And the other reason, of course, pedigree is ongoing still with Ipi-Nivo as an upfront therapy. But no, excellent points. Absolutely. If a number of people are still prefer to treat with Ipi-Nivo, we'll definitely take that into consideration.
So I think Pedro's going to slay it at the next task force meeting, and I think
All
that's
right.
probably going to be discussed. I think Monty, being a very good salesman, knows what's going forward in Alliance and is trying to be respectful, but the task force ultimately might change the approach, and we're getting in our concept first due to wonderful efforts from Pedro and Kathy and the team.
Yes.
Just FYI, about an hour ago in the committee chairs meeting, the NCI presented a rapid approvals mechanism called the CTIU, Clinical Trials Innovation Unit. They are going to be requesting, in fact, I was texting Ulka earlier on, they're going to be requesting the cooperative groups submit And so clearly, as Lucky said earlier, this is the most shovel-ready of all of them. So don't even, at least at this point in time, I wouldn't consider the task force or even the steering committee. This needs to be taken care of ASAP. Are there any, Pedro or Ilka, are there any other organ sites that are for IO that this would be appropriate, most appropriate for? And I just ask you, are there any in which it would not be?
Right. I think
because then you could think about it's a much, it's a make your brain hurt.
Right.
You could think about a basket trial of some sort.
Yeah, I think it depends how we see it. If we, and I think the comment regarding what IO-based combo would we do with this, I think is a very relevant one, and we're trying to be respectful also of what's going on in the, the landscape of the all cooperative groups. I think the comment would go actually beyond ipi/nivo and just say why not include any IO-based approach, right? Because this will be fair as well. I think we have to see what happens with the discussions moving forward for a label to that, and I think it's possible as long as we strat. But addressing your question at the time, I think diseases where, for instance, ipi/nivo is considered standard of care, I would see this kind of concept being easily adopted there, right? I'm thinking melanoma, for example.
Melanoma is the most
right?
obvious.
That would be one, because for IO TKIs, I think the gynecological oncology group does have, LAMF-PAM, for example, in some of the gynecologic cancers. So we could explore the IO TKI also in other solid tumors beyond GU. And then there's a question on the chat regarding if there's a plan for early analysis, so I'll read it as a futility, and the answer is yes. It's a great comment. The thought process is we don't want to enroll 800 patients without knowing what's going on, and I believe a great job from Kathy, and again, from what I recall, we have 3 interim analyses, I believe, and the first of them would occur around 160 events, and I think that's about right. Kathy, I don't know if you want to add anything to that.
Yeah, we had an alternative design too that we were kicking around, which is a phase 2 threshold, even being more cautious and saying you have to do a certain amount of activity at sort of the smaller sample size phase 2, and then if that looks good, go on to the phase 3. I mean, that's more of a political getting everybody to buy in and not feel like we're sucking too many resources. So we could still talk about that, but I think for the task force, we didn't put the phase 2 piece in, but it's an option.
Yeah,
And
and the reason we didn't is there could be, we would lose momentum, and really the toxicity of this added compound has not been a big concern. So those were the reasons, but I mean, we'll see.
In terms of adding another cohort, if we're going to add other disease states, it makes sense. Monty and I have talked about what about moving this up in adjuvant. What's moving forward is not that exciting, and Chris can tell you we've, the concept in Alliance to use Axi-Pembro is not that exciting versus Pembro monotherapy. So potentially, instead of doing a smaller cohort or another disease, we can just potentially expand to an earlier stage clear cell cohort.
I think that
comparing
is
Pembro
effective.
plus or minus this.
Yeah.
And just have
one
one quick.
last comment I will make. Please, if you have any exciting correlative work that you're doing in this field, please contact us as soon as possible, because like I said, this study is really hoping to move pretty quickly. So if you do have something that you'd like to consider us plugging into this, that we can look at, please contact us.
Can I just ask in the room here, who would enroll for this study? A show of hands. Okay, pretty good crowd. Okay, thank you.
Thanks. Okay. So we can.
All right, thank you, guys. And just excited, we'll keep updating you guys as to the status of this study.
Okay, so Jen unfortunately had to jump off as she's presenting at her cancer center, but Jen Liu, appreciate her help putting this together. And also Deepak is at a wedding. He stepped aside from his brother's wedding to present as well.
Oh my gosh.
Yes. So he showed me a nice picture of a family member on a horse, which he stepped aside on. But Deepak will be joining, but we have never had a really early stage concept in any of the cooperative groups other than what we consider adjuvant therapy. We have monthly calls. I would love to have more people on. Some people unfortunately fell off, but we will definitely have Megan kind of add people back in. I just want to kind of give some background. Jen was going to go over this. Chronic kidney disease is obviously something which all of us are aware of. We have different stages of chronic kidney disease, and about a third of our patients with chronic kidney disease with renal masses have some pre-existing CKD. There's been a landmark, paper looking at how CKD can affect overall outcomes and survival. And this New England Journal paper really just showed it's not all or none, whether you're on dialysis or you have good kidney function. And if you just look at the bottom, if you have a patient with like a T1B renal mass with a CKD stage 3, if you do a radical, you might park them in that stage 4 category. If you do a partial, you might park them at that stage 3 category, and maybe it has some bearing in their overall health and well-being. We do know that patients may go from bad to worse, and those patients who have pre-existing chronic kidney disease, when they have a nephrectomy, they may progress more rapidly towards further renal decline. And in patients who have some evidence of chronic kidney disease on their nephrectomy specimen, they may have further decline. And obviously diabetes and hypertension can further potentiate their further renal decline. And obviously CKD stage 4 or 3 is important. We do know that partial nephrectomy may be preferred for some patients. This is a VA study from John Leppert looking at patients who had a partial versus radical nephrectomy, and the patients who have a partial nephrectomy may be spared from progressing towards stage 4 CKD, which is important, and they may have overall improvement in mortality. But this, which Jen was going to show, is that doing more heroic partial nephrectomies may put patients at risk of complications, maybe risk of death if they're going to have really a more heroic operation. Urinary fistulas, transfusions are greatly increased if you're going to be doing a more complex partial nephrectomy. And in reality, almost half of our patients who do have a radical nephrectomy, they may completely recover their pre-existing level of kidney function, especially women, those who have a higher GFR, or those with larger tumor size. And we have to also be very cognizant is recurrence has consequences. This is a patient who was treated up north here, and this patient had a partial nephrectomy. I saw this patient, and I would argue that that patient with a biopsy-proven grade 4 unclassified tumor with sarcomatoid features with a normal contralateral kidney probably shouldn't have had a partial. Our guidelines aren't very helpful. We have our clinical guidelines just showing, stage 1B, stage 2, you could do a partial or radical. And our AUA guidelines, this over here they're not really that helpful. If our AUA guidelines say a radical nephrectomy should be preferred only if all of these are satisfied. High tumor complexity, no pre-existing chronic kidney disease, a normal contralateral kidney, and if your new baseline GFR will be greater than 45. To meet all of those, I'd say it's a very high bar to say that radical nephrectomy would be preferred. Anyone with stage 3 CKD is going to have a GFR less than that 45. So according to our AUA guidelines, pretty much a partial nephrectomy should always be preferred. And we know that that's not always true. So I'm going to hand it over to Deepak. If you're on Deepak, I'll just show you this type of case.
All right, so we got a couple of cases and a couple of different concepts. Many of the urologists in the crowd have seen cases very similar to this. So this is one case as an example, 58-year-old female, 5.8 centimeter renal mass, clear cell, grade 3, solitary kidney, nephrometry score of 11. You can see it's really hilar. You see some vessels there. GFR pre-nephrectomy is 52. And she had a prior tumor removed 10 years before. So she had, this is, I think, one of Brian's cases, a prior embolization in China twice, 7 and 5 years ago. And this tumor, which has been embolized, continues to grow. And clearly this patient does not want to end up on dialysis and chose these alternatives. Next slide. So one concept which has been played around in a number of trials, you can see that on the right-hand side of the screen, this concept of downstaging. And you can see There's a few trials here. There's the Padres trial, pazopanib trial at Cleveland Clinic. In France, they had the Apixant trial. And in these studies, they had patients with bigger tumors. Some of them had high, good GFR. Some of them had low GFR. So certain different ways of doing that. And but in this sort of proposed concept, it would be patients for us. You can see clinical stage T1B to T3, clear cell, renal cell, nephrometry of 9+, where the urologist who's seeing the patient thinks that, obviously a partial nephrectomy would be preferred, but it's going to be tough, just like the case we've shown before. And so in this, the patients would be randomized to either neoadjuvant systemic therapy, or they get the standard of care. And it's left up to the investigator if they feel that a partial is possible. And so we have a few kind of questions about this study. And, do we consider a single agent? We're thinking about toxicity, or do you use dual agent? Would urologists be comfortable to wait up to 12 weeks prior to performing the surgery? What kind of outcome are we looking at? Are we looking at renal functional outcomes, or do we look at a hard outcome such as organ preservation? And secondary outcomes would be response rate. And there was actually one randomized trial out of Germany that was published, a small study where patients were pre-treated with systemic therapy, and then they actually examined the tissue after partial or radical nephrectomy, and they looked at the intratumoral heterogeneity. So it would provide an opportunity to look at what changes in the localized disease setting would pre-treatment with systemic therapy, what would that do? So these are just some things to think about. I'm going to show you kind of another concept, and then at the end we'll kind of, or do you want to maybe get ideas right now, Brian?
Yeah, maybe we just opened up we have time to just some feedback here. I mean, again, we also thought that a placebo would not really be ethical here. Patients should just go immediately to surgery. The idea of, we know a TKI for downstaging, I mean, the outcome will have to be creative. Is it just GFR? Is it avoidance of stage 4 CKD? Is it volume preservation? Ian, love to get some thoughts.
I'm just wondering, it kind of reminds me of bladder sparing, right? So for a smaller mass, an ablation in combination is are there any trials that you're aware of, a systemic plus ablation, a bit, akin to bladder preservation?
I'm not aware of any, because usually those are going to be much larger masses and all these trials on the side. Yeah. Seth, any of our medical oncologists about, just a TKI or just a TKI IO?
I'm not sure I get the idea here. Maybe I just wasn't paying attention, but so conceptually, where does the field of neoadjuvant systemic therapy pre-surgery sit for this patient population?
So there's Axel Beck's had a trial looking at priming and trying to call it it's a avelumab and axitinib trial, really trying to improve, recurrence-free survival. This is more of just basically we are trying to basically maximize renal function in patients who will potentially, be facing really significant chronic kidney disease.
So what's the data to support downstaging?
There's a lot of trials just showing, like MD Anderson, Cleveland Clinic, you're able to make a tumor which was going to go for radical into a partial, or you'd be able to maybe spare more parenchyma.
Yeah. So then where the rubber hits the road is you have to be very precise about your eligibility.
Yeah.
Right? Because you have to be able to, presumably there has to be some measurement of, actual objective downstaging. And I just wonder if that's possible to really make that objective and reproducible. It may be. I appreciate that the nephrometry score is a way to do that.
Yeah.
But I also wonder, how many of these patients are really out there? And you would know better than I do. I mean.
Yeah, Sia sees most of them. Yeah.
I don't think so. No, I just had a comment. I mean, I share your concerns, but I think Brian's right. There's plenty of data to suggest you could downsize these to make it more feasible. Otherwise, this patient would get a radical nephrectomy, and that's the outcome. Can you do a partial nephrectomy in this? And then you'll follow them. But my other concern, on the one hand, I would favor as much therapy up front as possible to downsize. On the other hand, I have slight concern, having now done, I'm sure you've done even more, nephrectomies post-IO therapies and the intense sort of desmoplastic reaction. So the more response we have, the more difficult the surgery becomes, as in any disease state. So do you anticipate it'll make the surgery potentially even more difficult?
So I think that's a good argument to just do a TKI alone, because the IO might be becoming a little more inflammation. So
on the other hand, you may
yeah.
get more response from it. So.
Yeah, I think, there have been some other studies, and they did, every low study has, to Seth's point, different criteria for what is a response. Some people say, does it get off the hilum? Does it get off the vessels? And they've looked at that, or shrinking it by 3 millimeters. That's in one trial that was done, that was one of the outcomes. So there are different ways to, I guess, measure quote unquote success. But we felt that some of those would be a bit challenging because, at the end of the day, the objective is to preserve the organ if possible. And so we said, is that this primary outcome? Can we, does pre-treating with 3 weeks, with 6 weeks or 12 weeks of single or dual agent, does that result in more patients who preserve their kidney? And without getting too much into the weeds about, it shrunk 25%, or it's 2 millimeters smaller, that's kind of where we were thinking with that.
So I don't want to hammer too much into the weeds, but we're trying to reinvigorate this space and in this potential not so rare but pretty common space. So this is another kind of potential idea. So Deepak, take this one away too.
Yeah, so this is just another kind of exemplary case. So here's a 73-year-old man, 5.8 centimeter renal mass, nephrometry score 11. You can see it's right in the heart of the kidney there. History of hypertension, pre-existing renal disease with a GFR of 49, and normal albumin creatinine ratio. Would you choose a partial or a radical? And if you look at the AUA criteria that Brian had sort of outlined earlier, this is a high tumor, complexity. A partial is going to be challenging. So, that might favor radical nephrectomy.
And these are not rare patients. Like I said, these are patients we see in our clinic every single week. I usually would send this patient to SIA and say, deal with it, but yeah.
Yeah, this patient doesn't have proteinuria. He's got a normal contralateral kidney. But if you take out this kidney with a baseline GFR of 49, he is definitely going to have a, post-op renal function of worse than a GFR of 45. So according to our guidelines, they would say that, a partial should be the treatment in this. But when we look at it, we know this is going to be really tough. So that kind of just, we'll go to the next slide to kind of lay out a potential other concept.
And so I'm just going to say that there's been other things done in the space. Obviously, we have an EORTC trial, 5 centimeters or less, normal contralateral kidney. We had a concept that was put forward with 2 healthy kidneys with outstanding kidney function doing a partial versus radical. What Deepak is going to go over, this is a different disease space. This is patients with pre-existing CKD.
Yeah, and these are, many of us have these patients who say they'd rather die than be on dialysis. I mean, I see this weekly. And so, this is another way to potentially investigate this study population. So these would be patients with T1B disease, high nephrometry score of 10 plus, pre-existing CKD 3 plus, where you calculate their post-op GFR of less than 30. And we know that those patients will progress to dialysis. And so these patients, may choose to have a radical nephrectomy, or some will, really want a partial. So we would sort of, this would be sort of investigator, and this is something we would discuss, like your opinions on, but investigator sort of driven randomization, and then consider an endpoint. And there have been different endpoints in this disease space, but we thought of a composite endpoint and wanted to open that for discussion. What do people think of looking at a composite of time to death by any cause, local or distant recurrence, or the development of end-stage renal disease? Of course, we have the secondary endpoints, which are important, the adverse events, cancer-specific survival, time to recurrence, the cardiovascular-related morbidity, perioperative complications with the urinary fistula and leak, reoperative procedures and whatnot. So, what do people think about this concept of, these would be patients who are not pre-treated. They don't get the toxicity of systemic therapy. And it answers the sort of question, is it better to do a radical nephrectomy in this group or a partial nephrectomy? And with a composite endpoint, we may be able to define that difference better.
We're trying to get a little more creative. Obviously, it's very hard to do a trial when outcomes are great, but these are patients we see very often and we are struggling with. So we kind of came up with two potential different ways to go, and we're definitely wanting feedback about maybe what's the best approach. Seth?
This strikes me as a really hard randomization, because I would think that most of us are going to look at that and go, imperative partial. And, if it's technically feasible, and not take the risk with a radical nephrectomy. So I would find this very difficult to randomize in favor, sort of focusing on the kidney preservation, one of those kidney preservation strategies.
Niraj?
So I have completely different comment. We really need trials in neoadjuvant therapy or surgical field of kidney cancer. Our urologists keep asking if you have a trial or not. Industry will rarely be interested in a trial in this context. So I think we need trials. So thank you for thinking about it. Yeah.
Okay, Laura.
Hi, and hi, Deepak. Thanks for dialing in during your brother's wedding. It's Laura S. Feller. I really like the design of both of them. I'm leaning more towards A, though, just because I see a lot of patients that get radicals that really should get partials. So I'm a little concerned about accrual for this one, although I think it's something that's really important, especially for these smaller tumor patients. But I think if you're going to go with A, I probably would lean towards just the TKI, just because less toxicity. But great work, guys. Thank you.
Sia?
Sorry, just completely agree. I just wanted to put in my comments here. I think this concept will have significant challenges to accrual. I think it's very, very difficult to randomize patients between partial and radical in this particular setting. So I really liked your first concept. I think we'll have significant challenges here.
Okay, Guy?
Yeah, I agree too. I think probably a mix between these two concepts will be the sweet spot, meaning if the patient is already eligible for a partial, then it will be hard to measure what's the benefit of neoadjuvant therapy. But if you have a patient that by eligibility criteria will be partial, but it is not in practical terms because of location, because it's central, or you don't feel it's feasible, and it would do a radical instead, then I think a neoadjuvant may give you the gain, and the endpoint will be kidney preservation. So patients borderline criteria for partial, that the surgeon actually would recommend radical, and then in those patients is the therapy able to save that kidney and the downsize enough to become a radical or partial. I think that will be where we will be leaning in terms of sizing and a nephrometry as a criteria for selection.
Perfect, thanks.
Can I just add something? In the comments, there was a comment about potentially exposing someone to lifelong IO toxicity for a T1B or T2 clinical mass is not too appealing. So, from the medical oncologist, even at the expense of potentially response rate, are you favoring then VEGF or TKIs as solitary then? Is that the sort of general feeling with the concerns with the IO toxicity?
Yeah, there was the comment about exposing someone to a long-term IO toxicity. I would say someone with a solitary kidney, you also probably have worse outcome if you put them on dialysis. Pedro?
Yeah, Brian, so just two brief comments. I agree with what was said before in the sense that every single tumor board on a weekly basis, I'm asked, can we do some sort of neoadjuvant therapy? So I definitely agree that we need studies in that setting, right? So that's one. And number two, every time we think of a neoadjuvant approach, even for thinking about resectability and this and that, I do think TKI monotherapy is probably not attractive. And actually, I think all of us have a few cases in our clinics where we've done it off-label without mats, and I would argue most of those patients got an IO TKI approach and not a TKI, right? And so yes, there are reports about concerns regarding IO and the effect on primary tumor. To my understanding, those reports are relatively uncommon / rare. is something that we're aware, but and finally the data is about 20% or so for TKI, even though that Azim has data from Emory about 28, 29% with Cabo, but then, as you mentioned, pointed out, seems like Niobe's approach, at least with axitinib, but I would argue probably with others, will probably lean towards the ballpark in the 30%, a little bit more, which is actually what we expect, right? That discrepancy between primary tumor shrinkage versus metastatic disease in the stage 4, it seems like we have about 30, 40 maybe % in the primary tumor response, which is contrasts with perhaps 60%, 50, 60, 70% in the distant side. So anyway, I just want to share that thought from a med-onc perspective that I think the TKI monotherapy might pose a little bit less attractiveness to folks out there, I think.
Got it. So we're going to continue working and trying to refine this. And again, we want as many people to get involved. And, this is hard space to get into without seeing outcomes, which is obviously a good thing. Just an update. So again, we've discussed this ad nauseum, but we have a potential fix for this trial. This was a trial through the CTPM about 3 years ago. It was basically the endpoint here was showing that a biopsy would improve intervention-free survival. We know there's gross, massive overtreatment in the field of kidney cancer, and we were going to randomize patients to a biopsy or no biopsy. This went through 4 SWOG meetings, CTPM. Deepak brought this to the Young Investigator course. But basically, we know about 25 to 30% of small renal masses are ultimately benign. And by doing a biopsy, identifying some of these, we potentially would have patients who would elect not to have upfront surgery, and we'd be able to limit overtreatment. But we kind of stalled on this because this trial was moving forward. I was the lead of this trial. Basically, it's a CA9 antibody-based zirconium-labeled PET-CT. We presented this at ASCO GU. It was basically an image and resect trial. The goal was to basically see the sensitivity and specificity of detecting clear cell kidney cancer. And as we knew this was coming down the pipeline, it was a little bit concerning how it would affect our trial. But basically, it was 300 patients, 288 that had central path and central radiology review. And the data, just looking at how it would affect our cohort, the data there's very little toxicity. All the toxicity of the trial is related to a nephrectomy. But the positive predictive value at detecting clear cell kidney cancer was 93%. And the patients who were false positives were all high-grade papillary. CA9 is not unique to clear cell kidney cancer. It's expressed due to hypoxia. Their breast cancers, bladder cancers can be hypoxic. So you could argue that the positive predictive value to detect cancer is nearly 100%. So in our group calls, we said that this probably is going to change how we approach early stage kidney cancer. So this manuscript is in preparation. There's discussions with the FDA that are ongoing. There's an extended access protocol. There's a submission to NCCN coming. And the company, which has worldwide distribution already figured out with Illuccix, a PSMA agent, they don't think that this is going to be hard to scale up pretty quickly. And they are expecting that maybe this could be widely available mid-2024. I would say that, who knows, the I-124 girentuximab went to the FDA. ODAC voted 16-0 to approve it, and FDA still did not approve that agent. So, but the company is hoping that if it does get approved soon, that it would be widely available, and they're also willing to support a trial. So just to kind of wrap things up, we think this may be the standard of care. We think that it does raise new questions about the role of biopsy, and in a way to salvage this type of trial, there are populations that are going to be zircon hot and zircon cold. And if we just put this up front, if everyone gets zirconium up front, I will argue that this is not going to be a way to salvage the trial as follows. If you put patients and give everyone up front, if we have a healthy, young, fit person with a zircon hot lesion, they're probably not going to want to get a biopsy, okay? So we think this type of approach, there would not be equipoise to randomize patients to a biopsy. So I'm just going to outline three more slides, we'll finish up. The patient population greatly impacts how you approach management. Small renal masses, they are found in young, healthy, fit patients. They also are in older, sicker patients with comorbidities. And doing a study with renal mass biopsy in the era of molecular imaging would be really powerful if it was broadly applicable across populations. And then just to kind of just show you the populations, we have patients we see in clinic where treatment is likely preferred. If I see a young, fit 50-year-old, I'm going to think about immediately, I'm probably going to want to treat them. If I see a 75-year-old patient where I could treat, I might want to potentially think of them as treatment preferred. And having a zircon hot or cold lesion, I would argue that this is going to greatly impact your thoughts. If you are a young, fit, healthy person, you have a hot lesion, you're probably going to proceed to treatment. If you are cold, you might want to potentially do a biopsy to maybe think about, will it limit treatment? If you're an older, sicker patient, but you are still eligible for treatment, and you have a hot lesion, you think it's a clear cell, you may think about biopsying that patient as an excuse not to treat them. And if you are zircon cold there, maybe the biopsy there may kind of push you. So I'm just going to outline where I think it's the final last slide and open it for feedback of where something like this more pragmatic design would take us. Patients who are candidates for treatment, they have a T1A, they have a lesion which is not, large, they're biopsyable. The provider thinks that maybe they're going to lead more towards surveillance. They get their G250 PET scan. There are going to be some patients that are going to be hot, some patients that are going to be cold. And this is where you randomize a cohort. For here, the zircon hot, maybe you biopsy them, and I would argue that potentially a biopsy here would improve your intervention-free survival. Because if you had a clear cell grade 1, grade 2 without sarcomatoid, maybe you would be willing to sit on this. Now the zircon cold patients, maybe you do a biopsy here, or you randomize them here, and you potentially could argue the hypothesis that a biopsy might maybe push you, your intervention-free rate would be worse with a biopsy. Now, again, they're the patients who have, maybe you'd think about doing an intervention up front. You would get your G250 scan, you would have your populations of zircon hot and zircon cold. And then if you were a young, healthy, fit person who had a clear cell, you probably would just treat them. I could argue that we potentially could add something correlative on the back end, which would be very interesting. But the zircon cold patients, if you randomize them to a biopsy or no biopsy, I'd argue there that you would still pick out the oncocytomas, the fat-poor AMLs with that. So I know it's very challenging. It'd be a large trial. I saw 8 patients this week that I probably could have put on this type of trial. And I think the hypothesis, again, if we consider intervention-free survival to be important, which was considered in the CTPM, you would potentially have very different cohorts here that potentially could show how biopsy would have impact in this new era of molecular imaging. So love some feedback on this. This is the only way we kind of saw that maybe could salvage this type of trial. Niraj.
So based on my knowledge of the Cancer Center Support Grant renewal, when the NCI review committee comes and they look for treatment trials, this will not qualify for treatment trial. That's my only concern. So
there's probably been hours and hours of discussion through the CTPM and in GU steering committee about having this potentially kind of fly. Seth knows more of those discussions, I think, but I think there was support through Bhupinder and the NCI leadership.
It was just a comment.
Yeah.
This is a great trial. I'm not talking.
If we make a clinical decision based on the data, isn't that considered intervention? I mean, even if you're avoiding nephrectomy.
Alka, the definition of interventional trial for the CCSG designation for a cancer center is if you are improving the outcomes of cancer or cancer-related treatment. They are very specific about it. So this, I'm not saying trial is bad or good. I'm talking about the attraction among investigators and buy-in from the cancer center leadership for these kind of trials.
That's okay.
Yeah, I mean, this is the same endpoint we had before with the other design, intervention-free survival. You can say renal intact survival, you can say bladder intact survival, it's still, avoidance or a change in treatment.
I would venture to say this is a very clinically meaningful endpoint that you've picked here, Brian. I mean, I'm a big supporter of this, and I just think it's just so incredible how you've been able to very pragmatically shift the original design towards this. I actually like this a lot more, than the original design, in that it really sort of incorporates that investigator bias, acknowledges that, and I think that's so key in a trial like this.
Yeah.
I agree with Monty. I do like this design. My slight concern might be that, when PSMA PET came out, it wasn't available everywhere. And how much is this going to be, easily available for us to do it across all sites? So that may be a slight stumbling block potential.
Niraj?
This scan will be widely available. I have no doubt.
Well, that's not going to be a problem.
It's a matter of time. I'm like maybe 6-7
Yeah.
months. But I want to reiterate, this is a fantastic design, very pertinent trial. I was just talking about making the endpoint more clinically related to meet the definition of treatment trial by the NCI. That's it.
Yeah.
And maybe the urologist in the audience could comment too.
Yeah, Ian or Seth, yeah, or anyone else. Just, I mean, again, we're trying to salvage this trial knowing that this is, or Dan, that now we have this new molecular imaging agent, and still there's going to be a question of what's the role of biopsy in those populations. Seth, yeah.
Yeah, I mean, given the history of this, it's absolutely worth pursuing. My only comment is relatively minor. I think I asked you this before, is that, and I appreciate that people are operating on patients with tumors that are 1.5 centimeters. I'm not one of those, and I would just consider maybe just cutting it off at 2 centimeters. And I'm not sure exactly why the upper limit's 3.5 as opposed to 4. But those are little details that can be worked out. I think this question of whether it qualifies as an intervention or a treatment trial, that should be pretty easy to clarify, and it's maybe somewhere in the middle. To me, it looks like an intervention trial, as opposed to the microRNA trial, which is a wonderful trial, for testis cancer. That's not an intervention; that's a biomarker study. If for whatever reason it was deemed to be a non-treatment trial, there's certainly other mechanisms within our organization here, DCP. I wouldn't fret too much about that right now, because you've got a timeline that has to evolve, and I would continue, chewing on it and working on it.
Yeah. Dan?
Yeah, I like the revisions. I mean, we've been through this a long time. I guess just two things. One is, do you have a back of the envelope numbers, and what's the effect size? Because, you're talking about 12.5% improved, intervention-free survival going up or down a few percent or something like that, or what is it? What is your...
Yeah, I mean, we were just kind of playing around with some numbers. Kathy hasn't looked at it, but I mean, this is a large trial, like 2,000 patients. But again, I mean, there's 80,000 new diagnoses a year. I mean, most patients don't make it to the medical oncologist because we see them and we treat them. But, I probably have 200 patients in my clinic that I would put on this each year if I could convince them.
But you're saying about 2,000 patients to change the intervention-free survival from a...
No, because it's really would be 3 different trials.
Yeah,
three different
I
baskets.
I get it,
Yes.
but the clinically, can you just give us an idea of the effect size that you're looking at?
It'd be like it'd be about a 12% to 25%, in that you can argue which population, but like a hazard ratio of like 1.3 to 1.4.
Okay.
Yeah.
My only other comment would be, in the Zircon hot, I mean, this is great because it's taking into account provider biases. What about patient biases? And if I was a patient, I thought I wanted to observe a tumor and it was Zircon hot, why get a biopsy? And the PPVs are well over 90%, as you said yourself, maybe 100%.
Yeah.
The NPV is down, I saw it be 80%. So
Yeah.
why in their Zarcon Hot that you're preferring to watch somebody, we know that person has cancer, why would they even get a
Well, in the young, healthy, if it was you and you had a zircon hot lesion, there's
No,
the
the top one, preferred a.
In the 75-year-old who's had 2 stents, you know.
Why biopsy the patient? That's what I'm saying. The patient will not want a biopsy if they know 95% of the time they have cancer.
But then are they going to go for treatment?
No, because they don't want treatment. Neither do you.
Yeah.
I'm just saying that the top one is a tough one, I think, for patients to accept. That would be hard.
Yeah.
A sick patient who has a known tumor, no one wants to do anything on that. They're zircon
Yeah,
hot.
but again,
why
you wouldn't put them on the trial because these are patients who are candidates for treatment and would consider treatment, but you're leaning.
Preferred AS.
Yeah.
That's-
Yeah. Thanks, Dan. Okay. And that's it. But any other thoughts, please let us know. And again, we have our monthly calls for kidney. Megan can add you to the list server. We'd appreciate more help. Thanks.
First Tuesday of the month at, 5 p.m. Pacific.
Thank you all for staying so late. Have a safe trip home. We will see you in 6 months. And thanks to Brian.